Welcome everyone to another exciting edition of NeuroConnect, our weekly live event dedicated to unraveling the wonders of neuroscience. Together with eminent experts in the field, we aim to support and empower both patients and caregivers as they navigate the challenges of living with neurological conditions. I'm Deepa Tatkare, your host for today's enlightening journey through the ever evolving landscape of Parkinson's disease. Our focus this week is on exploring the evolving landscape of Parkinson's disease and discovering new therapies on the horizon. Parkinson's is a complex neurological condition that affects millions of people worldwide. It is characterized by a range of motor symptoms such as tremors, rigidity, and slowness of movement, as well as non motor symptoms including cognitive changes and mood disorders. Parkinson's disease is a condition that not only poses physical challenges but also affects emotional and social well being. While there is currently no cure, significant progress has been made in managing its symptoms and improving the quality of life for patients. Through the collective efforts of researchers, healthcare professionals, and the support of communities, we strive to enhance our understanding of Parkinson's and discover new therapies that hold the promise of a better future for those living with this condition. To drive this further and strengthen our understanding today, we are privileged to have Dr. Jackie Ganguli with us, a true trailblazer in the field dedicated to transforming lives and leaving an indelible mark on the evolving landscape of Parkinson's and movement disorders. Dr. Ganguly is a distinguished specialist in Parkinson's disease and movement disorders at Institute of Neurosciences, Kolkata. Dr. Ganguly's unwavering dedication to improving the lives of those battling movement disorders is truly inspiring. With comprehensive training in diagnosing and clinically managing various conditions, including Parkinson's disease, tremors, atypical Parkinsonism, and dystonia, he stands as a beacon of hope for countless individuals seeking relief. But that's not all. Dr. Ganguly's passion extends far beyond the clinic. His relentless pursuit of knowledge has led him to explore cutting edge therapies like botulinum toxin treatment, deep brain stimulation, programming, levodopa carbidopa intestinal gel, and apomorphine. Beyond his clinical practice, Dr. Ganguly's passion for clinical research is evident. He holds a profound interest in clinical genetics related to movement disorders, a field that holds a special place in his heart. Welcome, Dr. Ganguly.
Thanks, Deepa, for nice introduction.
Yeah, thank you. Thank you for joining us.
Thank you.
Before we begin the discussion, we encourage our audience to ask questions and share experiences as we strive to make this event interactive and informative. We will be addressing these questions at the end of the session. Without any further delay, let's now start today's discussion. So, doctor, to begin, let's address one of the most common questions that individuals often have. When can a patient think they are having Parkinson's disease?
Yeah, so this is a very common question when patient will think that I have Parkinson's disease or not. The common four symptoms that we always teach. One is tremor, one is slowness, what we call it bradykinesia, one is rigidity or stiffness, and the fourth one is postural imbalance. So we just created a mnemonic, so we call it trap symptoms. Are you trapped in the trap? So TRAP, very easy to remember. T is for tremor, R for rigidity, A for this akinesia or bradykinesia means slowness, and postural imbalance is the P. So whenever your friend, your relatives, your neighbors are developing these kind of symptoms with tremor, with some stiffness, their daily life is becoming much more slow. All the activity of daily life like washing, taking clothes, clothing, unclothing, even simple works are taking much more time. So that's the clue when you should think that maybe you are developing Parkinson's disease. But we have to always clarify that the tremor does not mean only Parkinson's disease. Tremor can be from hundreds of causes. One of the most common cause of tremor is essential tremor. So patient many times think, okay, I have tremor and this is Parkinson's disease, but that's not the case. So whenever you feel along with tremor, all other symptoms, as we discussed, like slowness, stiffness, gait, means walking is becoming much more difficult. They are getting stuck while walking, tendency to fall while walking. They are getting stooped posture. As Deepa mentioned in the introduction, it's not only the motor symptoms. We have to also think of non-motor symptoms. One of the commonest non-motor symptoms are like constipation. We call it RBD or REM sleep behavioral disorder. That means some dream enactment behavior. Whenever at night they're screaming at their dreams, they're thrashing their limbs in their dream. Anosmia, loss of smell. So these can be common non-motor symptoms. Those can indicate that there is a start of some Parkinson. So whenever these kind of symptoms develop, always consult a movement disorder specialist.
Okay. So that means patients should always be vigilant about recognizing this type of symptoms for Parkinson's disease.
Yeah, absolutely. Whenever, not only on many times, what happens, these kind of subtle symptoms like subtle tremor, subtle slowness, patient may not feel that they are developing those. But the caregivers, the friends, family members, they many times realize, okay, I think you are taking more time than usual ones. Is your right hand having some tremulousness while you are walking? Or is there any change of the walking? We call it the shuffling gait, very short steps, shuffling gaits. So these are the features that think at least, okay, it may be not Parkinson's disease. There are hundreds of causes apart from Parkinson's disease, but Parkinson is the commonest cause, and this is the leading, as Deepa mentioned, this is the leading neurodegenerative cause worldwide. So whenever you notice these kind of symptoms happening, definitely consult a movement disorder specialist.
Thank you. Thank you, doctor, for clarifying that. Now let's understand some basics. Can you help us understand the difference between Parkinson's disease and Parkinsonism?
Yeah, that's a very nice question, Deepak. This is many times we face this question from our patients, and many times we see that patients have been evaluated elsewhere and there is a misdiagnosis. So basically, the term itself is Parkinsonism, and in Parkinsonism is an umbrella term. There are lots of disorders under this umbrella of Parkinsonism. One is typical Parkinson's disease, or we call it idiopathic Parkinson's disease. That's a typical PD, but we all know. The description what we have given, that a patient is developing these trap symptoms, slowly progressing. So that's classic typical Parkinson's disease. But there are some form of Parkinsonism, those are not Parkinson's disease, but still comes under the umbrella of Parkinsonism. So we call those disorders atypical Parkinsonism. Why? Because they develop similar symptoms like slowness, stiffness, some walking difficulty, but they are not Parkinson's disease. Why? Because they also have some other symptoms, those are not typically seen in Parkinson's disease. As you ask this question, this atypical Parkinsonism we grossly classify into four ways, like four types of atypical Parkinsonism. One is our classic corticobasal syndrome. So Parkinson-like presentation, but patient is having some posturing in the hand. Very quickly they are developing some fall. Progression is very rapid. You don't expect that fast progression in Parkinson's disease. So whenever patient is developing very early fall, like within 3 years, within 2 years, patient is becoming wheelchair bound. Then you have to realize, okay, it may be Parkinson-like, but this is not typical Parkinson's disease. Something atypicality is there. Patient may develop some jerky movement. We call it myoclonus. Those also indicate that patient may develop this corticobasal syndrome. A lot of dementia, very early dementia. If you feel in Parkinson, you may think, okay, it may not be a typical Parkinson's disease. Patient may develop memory problem or dementia in typical Parkinson, but that should take much time. If within 1 year, we call it 1 year rule, a patient developing that kind of dementia in a case of Parkinson's disease, like condition, you may think of whether this is a DLB or Lewy body dementia is not. Hallucination, frank visual hallucination within 1 year. Think maybe it is not typical Parkinson, maybe this is atypical Lewy body dementia type of Parkinsonism. Or MSA, we often see in our clinic, very commonly MSA comes is multiple system atrophy, when patient develop postural dizziness, like sudden getting up from the posture, like patient is lying or sitting, suddenly standing up, they are feeling dizziness. Why? Because blood pressure is falling. Suppose in the lying posture, supine and your systolic and diastolic blood pressure you are recording, and whenever they are standing, there is a marked drop in the blood pressure. So we call it orthostatic hypotension, means blood pressure is dropping whenever they are changing their posture. So these features will indicate, okay, this may not be typical Parkinson's disease. There is no absolute rule, but this classification is very much important, very, very important. Not only because from the prognosis part, definitely prognosis will be different. In the case of typical Parkinson versus atypical Parkinson, prognosis is different. And management-wise, it also has a lot of difference. So this distinction we have to do, and that should be done by a proper movement disorder specialist.
Right. Thank you for sharing those granular details. I hope that has helped the audience to understand the difference between Parkinson's and Parkinsonism. Now let's move on to treatments. What are the usual treatments or common treatments available for Parkinson's disease?
Yeah. So the most common treatment that is we all always prefer, this is Syndopa or levodopa carbidopa combination. There are different types of levodopa carbidopa combination. There is Syndopa, Syndopa plus, Medopa. So commonly we use Syndopa plus, that contains 100 milligram of levodopa and 25 milligram of carbidopa. So Syndopa plus is the most common and should be the first line of management for Parkinson's disease. But many times patient may not tolerate Syndopa plus because it has a lot of GI side effect, gastrointestinal vomiting. They may cause some vasodilatation. Patient may feel dizzy. So then we may shift to Medopa. It is levodopa with benserazide. So this combination also comes in the first line management. In younger patient, we many times use dopamine agonist like pramipexole, ropinirole. Those are dopamine agonists. These are also the usual very common medication. And then based upon the symptoms, like patient is developing off fluctuation, like the effect of levodopa is not lasting for 4 hours, they are getting off early. We use some medication like entacapone, Zafinact or safinamide. And similarly, if the patient is developing a lot of dyskinesia, like patient tense-like movement, chorea-like movement is happening, we many times use amantadine. So these are kind of common medications that you use.
Okay. So thank you for sharing those valuable options for the patients and caregivers to know. Now let's discuss advanced therapeutic options. What are the advanced treatment available for the patients with Parkinson's?
Yeah, so advanced therapeutic option, the most common advanced therapeutic option what we use is DBS or deep brain stimulation surgery. So the thing is, most important thing for DBS is not for everybody. So this is a common taboo, but we still have, and many times we get patients referring from any age and from anywhere. The doctor, I have to go for DBS. Is my father, is my mother, or is my husband, wife, whoever is fit for DBS. We want to go for DBS. We have to remember DBS is not for everybody. First of all, DBS should be done early in the age. Like if a patient above 75, normally we prefer to go for DBS less than 70 year of age. What happens after 70? The brain gets shrinking happens. So the brain atrophy happens. So the lead positions, what we use in the DBS is nothing like a pacemaker. Like a pacemaker in the heart, DBS is a brain pacemaker. So what happens if brain gets atrophied? There will be difficulty in proper positioning of those electrodes. And that may not give the 100% benefit. So less than 75, best to less than 70. Those patients who are having good levodopa response, like in some patient Even patients are taking 5 times, 6 times a day levodopa, but this is not doing anything. Patients are not turning on. Then you have to remember, even DBS will not make them on. So good levodopa response, number one. Proper age, early, less than 75, best less than 70. Third, no dementia or psychiatric features, like at least no significant dementia. If a patient having Parkinson with marked dementia, we will advise no, don't go for DBS because it may aggravate the dementia.
Okay.
And fourth is what symptom. We have to, patient counseling is very much important, and patient or patient caregiver should be having some realistic expectation that DBS will not cure the disease. DBS is a very, very good alternative for those patients who are having motor fluctuations. Like patient is taking levodopa, but patient's effect of levodopa is not lasting for 4 hours. It is just first initial 2 hour or 3 hour they are on, then last 1 hour again they are becoming off. And that on is a good on, but that the effect is not lasting. And there is no significant dementia, no significant psychiatric issue. Age is less than 75, definitely go for DBS. So that's the advantage of DBS. And in our center, in Institute of Neuroscience, we are doing it like every month we do at least 2-3 DBS. And we have proper DBS programming clinic. Every third Friday in the month, we do a DBS programming clinic because that's a software programming. And that definitely change the quality of life. It makes the patient's life much, much better. Apart from DBS, there are some other advanced therapies like your duodopa intestinal gel, or what it called duodopa. Duodopa actually is not much prevalent in India. When I was doing my fellowship in Canada, we used quite a lot of duodopa, but it is coming. So definitely in near future, we'll have some pump facilities. It's still there, but not much used. So it's something that we have to kind of get with it, and we can use it. It's a good alternative. And another one is apomorphine. Apomorphine is kind of for sudden off. Patient is doing well and suddenly they are becoming off. You have to go to market, sudden off. Then they can use the apomorphine as an insulin thing. It's exactly like insulin. They can just create a subcutaneous injection and they can turn on. And the apomorphine also has pump. And the fourth one is Botox. Botox is nothing advanced therapy for Parkinson in that sense, but Botox is kind of targeted therapy. As we discussed, many patients of Parkinson's and more for Parkinsonism patient, they develop this dystonia, this hand posture. And we can target botulinum toxin to make their hand much more better.
That's interesting. Deep brain stimulation offers hope for those who may have limited response to medication. So now let's
Absolutely.
understand what are the common complications of conventional treatments for Parkinson's.
Yeah, as I was discussing, common complication is number one is GI side effects. So a lot of patients develop this GI side effect with the medication. They develop nausea, vomiting. So we always ask the patient some strategies to take Sindopa Plus. So take it with full glass of water, because the problem is Sindopa Plus get absorbed from the lower duodenum of jejunum. So whenever you are taking the medication, take it with full glass of water, so that you have to, like a toilet flushing, you have to go down. No protein for 1 hour. Why? Because the receptors, those absorb the Sindopa, they are same as like a protein. So there is a competitive inhibition, and always if you take protein within 1 hour, that will win the race. So take levodopa each time with full glass of water, no protein for 1 hour. And if still patient get this kind of nausea, vomiting, or gastrointestinal side effect, initially we use some anti-nausea medication like domperidone. And if not, as we discussed, we may shift from Sindopa Plus to Madopa, that is levodopa with benserazide. That's the strategy we use. Next common complication is the dizziness because of vasodilatation. Again, these are the peripheral side effects. And we sometimes use again domperidone. And if patient can't tolerate, we may shift to benserazide or Madopa. Some other complications are these motor fluctuation and dyskinesias. These nowadays we are much more knowing that these are itself related to disease process rather than the side effect of medication. People initially thought, okay, there was a levodopa phobia. Whenever the young patients were coming, they said, oh no, don't give levodopa, just give some dopamine agonist because they may develop some dyskinesia earlier. Dyskinesia means this dance-like movement. But now we know this is not the case. that dyskinesia is integral part of the disease process itself. Even if you start early or start late, that will not matter. So levodopa still is the best drug of choice, and that's the best drug to make the quality of life better. And other one we already discussed, that off, that's also part of motor fluctuation, different type of off, like sudden off, wearing off. Patient sometimes will predict that, okay, I'm taking 4 hourly, first 3 hours I'm so nice, last 1 hour I am becoming off. So that's predictable wearing off. Sometimes it is non-predictable and sudden off I was describing. And in those cases, those apomorphine subcutaneous pump or sublingual apomorphine helps suddenly give you a quick on. So these are the common side effects that we always have to take care. And another one we must discuss is the hallucination. Many times we are facing a patient are coming to us with Parkinson follow-up, sudden behavioral side effects, psychosis, hallucination, delusion, all these things. They are seeing a lot of things. People are standing here and there, well, actually they are not. So whenever this happens, two things we always mention, first rule out. One is dyselectrolytemia. Dyselectrolytemia means sodium-potassium alteration. So check sodium. If there is hyponatremia, treat it, because that's one of the commonest cause of having this kind of aggravation of Parkinson's disease or this kind of psychotic complications of Parkinson's disease. Second one is infection, and urine infection is very common, or chest infection, urine infection. So rule those out first, because these are the common secondary causes, nothing related but indirectly related. If not, then we have to modify some drugs. Those drugs we discussed, entacapone, dopamine agonist, amantadine, those themselves can cause this hallucination and psychosis. So if a patient is having those features, just stop all them, keep them on levodopa, and that's the best, safest drug.
Thank you, doctor, for clarifying those details. Now let's move on to the next question. So are there any exciting new therapies on the horizon that could offer hope for improved management of Parkinson's?
Yeah, actually, see, it depends. Now we are more and more focusing on the targeted therapy for Parkinson. We know now this is a neurodegenerative disease,
Right.
And this is nothing like infection. Like in infection, people think, okay, people sometimes ask that how long we have to take Simdopa. The answer is lifelong, because this is neurodegeneration, and it is nothing like have a 2 week or 3 weekly course of levodopa as we used in infection, like ciprofloxacin or augmentin you are using. Just take it for 7 days and infection is gone. Parkinson will not be like that. So medication will continue, but now more and more we are advancing. We are doing some targeted therapies like freezing of gait. Patients are getting stuck while walking. They can't move. It's like frozen state. In those times, a special type of DBS is coming. We call it PPN, the target of the deep brain stimulation, while inside the brain there is a nucleus, pedunculopontine nucleus. So people have started doing it, and in near future we have a lot of freezing of gait patients. It's a very common symptom in Parkinson. So normally we don't target that. For overall Parkinson, we target subthalamic nucleus, but that's a new advance that is coming. We may target PPN, pedunculopontine nucleus, that will improve the freezing of gait. As I also discussed about duodopa in North America, in Canada, US, people are using. In India, not much centers are using. We are starting, so that's another new thing we can start. It's kind of a pump. Instead of taking oral levodopa, it's just like a pump. You can attach it, and automatically that will be continuous release of levodopa. When you need a kick in, you may just press a button. You will get some more levodopa, and in the liquid formulation, and that will be directly connected with the jejunum. So all this food stuff what we discussed, don't take it like no protein for 1 hour and take it with full glass of water. You can get rid of all those, because this is directly related to your jejunum. The tube is connected in your belly. So you need a kick on, okay, just press the button. You may have some more levodopa in your blood, and that's it. So these are the apomorphine still are coming. We are using apomorphine, but that has some special scenario as we discussed for sudden off patients. Apomorphine infusion pump, all people are also using. But remember, there is recently what I would like to mention, there is a gimmick kind of thing, and everywhere we are getting a video, and patients were asking, okay, some patient was stiff like a stone, and some apomorphine injection has been given and patient is running. So everyone is asking, okay, this is the magic. They have cured Parkinson, but that's not the case. Please mind that's not the case. Apomorphine, still we know that's an old drug, we are using it, but for a particular type of patient. And half-life of apomorphine is very less. So even if you give apomorphine, patient may remain on for just 1 hour. After that, you have to again inject or use a subcutaneous pump. So that's not the cure for Parkinson. There is a misconception or taboo that apomorphine has cured it. Nothing like that happened. It's just something to give a quick on. That's it.
That's indeed promising for the Parkinson's community.
And some other new therapy, one or two, they are coming. We are also doing in Canada. We are doing this thing. We call it non-invasive brain stimulation. This was transcranial pulsed current stimulation. So nothing in the DBS. DBS is invasive process because we are going inside the brain. The lead is going inside. But in non-invasive brain stimulation, we are stimulating through the current, but from outside the brain. By the brain mapping, we are stimulating that area, and that again is helping levodopa. It's not an alternative to levodopa. Levodopa kicks the ball out of the park. You have to, it's like Messi. You have to give levodopa, no doubt. But with levodopa, with the support of levodopa, you can use those so that you can get much and much benefit of levodopa. That's it.
Yeah, thank you for those details. Now let's understand, how does deep brain stimulation work, and who might benefit from this treatment?
Yeah, actually, I think we discussed this question just 2 minutes ago. The DBS is kind of just think in the brain circuitry, there is a junction station, what we call it, subthalamic nucleus, and all the Parkinson related circuitry is going through that junction station of subthalamic nucleus. What DBS does, DBS that cut that pathological circuitry by sending current inside the brain through the electrodes, and it's just a very remote control. So whenever we do DBS and we then give a small remote to the patient, so it's like you are watching a television. In one channel, you are feeling, okay, the sound is very less. What do? You just use your remote and increase the volume. And in another channel, you may see, okay, some people are screaming, so you want to decrease the sound. So you use your TV remote to decrease the volume. Same thing happens with DBS. So when a patient is developing more dyskinesia, like more movement than that is necessary, they may decrease it. And when patient is feeling off, like no movement, they can increase the voltage. So it's exactly like a remote control, but much more software. I will not go into that details today. So the basic pathology is that, and pathophysiology of mechanism of DBS is cut that pathological circuitry by sending the current, and that can be modified from outside. Some detailed parameter we can modify, patient can't, but we give some programs, program A, program B, program C, those patient can modify according to your need. If they are having more tremor, you can use this program. If you are having more walking problem, you can use that program. It is like that. And patient feed, we already mentioned, like a good levodopa response, age is less than 70 or maximum less than 75, cognitively good, well cognitively preserved, and having this kind of motor fluctuation. And after optimal medical management, it is not, sometimes patient come within 5 months of having Parkinson and say, okay, sir, why not go for DBS? We say no, because you are not until optimally medically managed. So do for good optimal medical management and check those points as we discussed, and then go for DBS.
Thank you for the explanation and the insights. Now moving on to the next part. What role does exercise and physical therapy play in improving Parkinson's symptoms?
Yeah, so exercise, this is a new topic coming up, and people are doing much more exercise. This is very good because initially people didn't know about these things. The main thing what we prescribe to our patient to keep your body much more mobile. Don't just sit and watch TV. It's nothing doing good. So do some aerobic exercise daily. Do some small weight training. Not like you have to lift up a huge weight. Do some aerobic exercise. If you don't have time to walk outside, just walk inside in your home in a walker. And that's fine. If you do some meditation, that's definitely help. But do whatever you are doing, whatever you like. If you don't like that part, you don't need to do it. In Canada, in different centers, we used to do rock steady boxing program. Even in India, we have in different parts, we have that program. Doing some boxing for Parkinson patient, it helps. And In Institute of Neuroscience, Kolkata, here in INK, we have a own group for dance therapy. So dance therapy is a very, very promising results what we are getting in Parkinson. So dance therapy is good. Do some aerobic exercise, do some small weightlifting, walk more and more, walk, dance, play, do your yoga, meditation, whatever you like, and keep your body active. That's the goal, nothing else.
Yeah. Thank you for that valuable information. Now let's understand if there are any promising medications that are being developed to slow down the progression of the Parkinson's disease.
Yeah, actually, the answer is no. Like a lot of medication have been tried to slow down the disease process. That can be a marketing strategy also for different drug companies. But practically speaking, there is no such medication that can slow down the disease process. All those trials finally have failed. What it matters, they make the quality of life better. So you can go from point A to point B, you can go smoothly or you can go like this. So this drug will make your journey smooth from point A to point B. The disease will progress to point B, no doubt about that. The question is how you are progressing. How is your quality of life? That's what this medication does.
Yeah. Further, we would like to understand how can lifestyle modifications and a healthy diet support Parkinson's management?
Yeah, lifestyle modification one, regular do some exercises and gait and balance training. We many times ask our patient and we have a proper PD protocol. Many times what happens, we'll write to physiotherapy and some those who are not properly trained, what they do the same physiotherapy for a stroke patient, for a muscle disorder patient, for a Parkinson patient, everything is same. But those who are trained properly for Parkinson's disease protocol physiotherapy, what we have in our center and many other centers. So those are dedicated physiotherapy. So please do those physiotherapies regularly. Do proper gait and balance training because those help. Some simple thing like if you are turning, don't turn like a pivot turn. Take a big loop while you are turning. You may feel okay, that's a small thing, but it may make a much more difference. Patient, you may prevent it from falling while turning. And then healthy lifestyle, healthy diet. For exercise, we already discussed. For healthy diet, we always ask them to take more of antioxidants. Antioxidants like take almonds daily, take green tea daily, take all those green leafy vegetables daily. Like take some spinach, kale, and tomatoes, all those colored ones. They are very good. Take some citrus food like vitamin C helps in getting good absorption of levodopa. It may make you quick on. So if a patient is having delayed on, suppose if you are taking levodopa but it is not making you on in 30 minutes, it is taking more time, then you may simply just add some vitamin C sachet or just add some lemon into it. And that will add vitamin C and that will give you a quick on in Parkinson. And yeah, these antioxidants, green leafy vegetables, patient many times have constipation. So take a lot of fiber, whole grain diet and fiber, flaxseed. These are the ones, soybeans, omega-3 fatty acid, any form of omega-3 fatty acid from the fish. Those are helpful. Turmeric in India, we always use turmeric. That's a natural antioxidant. And they may use your blueberries. Blueberries are not always available, but at least grapes are available. So these are things patient must take and avoid all those junk food. Avoid, stop smoking, stop taking alcohol, stop taking those canned food, those all those cold drinks. Or try to avoid as much as possible and take some healthy diet.
Yeah, thank you for those details. Um, but patients who suspect they may have Parkinson's or they are experiencing symptoms, whom should they actually consult?
Yeah, so they must consult a proper movement disorder specialist, Parkinson's disease and movement disorder specialist. Many times we are seeing these who are not that much of trained. The Parkinson's disease is a very, very complicated disease. Its diagnosis, its management, and going through the whole journey. That's most important. Parkinson's disease will not be just for a few months follow up. It will be years together. You have to follow up. You have to take decision. You will become like a family member of that patient. Every time they will ask you, like, sir, what is happening? What is, like, can you guide us? Is DBS helping option for not? Is there anything else you can do? So I think Parkinson, whenever patients are suspecting, definitely should go to a proper movement disorder specialist, not only just a general neurologist, but a proper doctor who is trained, who is have done a proper fellowship in Parkinson's disease and movement disorder.
Yeah. Can you also shed some light on how can patients and their families connect to the support groups and the communities for better management of Parkinson's?
Yeah, so every center, those who are dedicated to Parkinson's disease or movement disorder specialists are there. They have their own support group. Like we have our own support group in some other hospitals in other part of the, India. Like in Bangalore, they have, in New Delhi, they have. So those are the local support group. Definitely, they should enlist themselves, like as we do. We enlist them, and they are doing a regular online meeting. It's not always we have to be present. They just meet them up. There are some dance therapies. They discuss many things, and then there are some national support group for Parkinson, international support group like Parkinson's disease India, Parkinson Canada, Parkinson Europe. These are the common links. If they search in the internet, they may join there. It's free, so they may learn a lot of things as we discussed. And they held a lot of meetings, like online meetings, and they can participate. And we many times do some program, like last year we have done an international Asian Oceanian section Parkinson's disease program, and a lot of our patients joined here in Calcutta. And we arrange this kind of support group programs. So people should seek, and if they contact, I think, to a movement disorder specialist, definitely they will help them to find out, and they will help to link them with those groups.
That's great. These details will really help us. So next, we would like to know what steps are being taken to ensure that new therapies are actually accessible to are accessible and are affordable to all the patients.
Yeah, so in this case, the most commonly used advanced therapy is DBS. So our newer generation of movement disorder specialists, we are trying our best to get DBS in low cost, right? Because patient may not afford that much of 20 lakhs or 25 lakhs. But we are gradually decreasing. We are having the meeting with our DBS team, those people who are in this field, and we are trying our best. We are doing some research also, so that how we can make the DBS much more beneficial for the patient, much more accessible for the patient. And major thing is cost. Many times we face patient like who say, okay, so we are also thinking this is the best candidate for DBS, but we can't because they can't afford. But then what if they have this kind of patient? I would like to come to us, come to a movement disorder specialist, because we can arrange something, some different fundraising programs to help them, at least something, at least some help. And we can talk with those technical guys to make some agreement with a low cost. And we are doing this. We have done this for a few patients, and I think that's the way to go. And gradually, as we are becoming much more aware, we are using much more, then price itself will be much lesser. Now we are doing it around 15 lakhs, 18 lakhs max, uh, including everything. But yeah, that's, I think, much more cheaper than any other centers and in other costly therapies. DBS because make your quality of life much more better.
Yeah. Thank you for sharing those details. The last question that we have is are there any taboos connected with Parkinson's disease? Could you elaborate on whether there are some cultural stigmas associated with this particular condition?
Yeah, absolutely. There are a lot of taboos are there. First of all, as we say, many times people think, okay, Parkinson's disease, okay, that's a very bad disease. If you have Parkinson's disease, you will die within few years. But that's not the case. If you have typical Parkinson's disease, you may live as if you did not have the Parkinson's disease. So that will not be the thinking or the thought process or something bad has happened, because with medication definitely we can make your quality of life much better. Number two taboo, many times people think, okay, Parkinson's disease, as we mentioned, many times there are mimickers of Parkinson, and patient may think, okay, so hand is shaking, this is Parkinson. May not be. And the other thing is also true. Some symptoms patient may think this is Parkinson. It may be not Parkinson, it may be atypical Parkinsonism, as we discussed. Sometimes people think, okay, because of some social stigma, Parkinson patient may not go out, may not be, they are kind of isolated. It may be transmissible disease. It may create problem in marriage, in having children. No, absolutely nothing like that. Just do your normal stuff, as enjoy your life. Parkinson's disease, we are there for to help you to make your quality of life better. It will not do any harm. Just take the medication properly and just follow our advice, and we can make your journey better. We can't cure you. That's the thing. The patient have to realize we can't cure you, but your journey, your quality of life will be as normal as possible.
Yeah. Thank you. Thank you for sharing those details. Thank you for sharing your expertise. It was an interesting discussion. And I hope the audience must have gained some insights and some knowledge out of this. Thank you for that information. Now, let's take questions from the audience. Um,
I think
so,
because of lack of time, only 2-3 questions maximum.
yeah, I suppose we just have two questions from
Oh,
audience.
okay. So just
One
quickly.
is, pardon?
No, just quickly we can go through.
Yeah, sure. So, first question is, what tests or tools are used to determine Parkinson's disease?
Yeah, so Parkinson's disease basically is a clinical diagnosis. Okay, we don't need anything. Clinics matter. So that's why if you are coming to a movement disorder specialist, just clinically we can diagnose you this is Parkinson's disease. But sometimes we have to take some test, what you call the TRUDAT scan or dopamine transporter scan, and that will show you that okay you are having dopamine deficiency or not. But that's for few cases where we are having that kind of dilemma. Okay, we are thinking it may not be Parkinson. In those cases, we can go for TRUDAT. But most of the time, 90% of the time, we just diagnose them by clinical.
Okay, thank you. The next question the next question is around: are there any ways to slow the disease progression?
Yeah, so exactly what we discussed are all those. There is no cure, but we can not only slow down, there is also a controversy of slow down the disease process. It's more of making your quality of life better, making your journey better through this point one to point two. Some of these, if you follow those drugs regularly, do this kind of healthy lifestyle, quality of life, your regular diet, and these will somehow little bit it may slow down, but there is no objective measure till now to show okay this is a definite. If you do this, if you take omega-3 fatty acid of this amount, it will slow your disease process of this amount. No, there is no data on that. But yeah, some slow, and more importantly quality of life, that's what it matters.
Yeah. So, thank you, doctor, for addressing these important questions and providing valuable information on Parkinson's disease management. We hope this conversation has been enlightening for our audience. Thank you for joining our event today. We
Thank you,
hope
thank
to
you,
have you with us again in the future as we continue to raise awareness about neurological disorders.
thank you
Your
so much.
continued support and participation would be invaluable in our collective efforts to make a difference. Thank you.
Thank you so much.
So, every individual's journey with Parkinson's disease is unique, and it's essential to work closely with healthcare professionals to find the most suitable treatment approach for each person's specific needs. If you want to know more, you can always download the Nuria app for interesting insights on treatments, clinical trials, physicians, and so on. Now, as we have come to the end of the session, I thank you all for being so engaging. Join us again next week as we explore modifiable risk factors and prevention in Alzheimer's disease with Dr. Vishwambar Bandare. Until then, take care and stay curious.